Yeah. Thumbs up, two thumbs up.
Thumbs
Two
up.
enthusiastic thumbs up. All right. So hi guys, my name is Katya Goldflam and I am currently faculty at Yale University, and the person alongside me, so to speak, figuratively, is Leah Bright, who is from Johns Hopkins University, and we're going to talk to you guys about palliative care and try to answer the question, why is palliative care not everywhere? And obviously we feel like it should be, so we will give you a little bit of a talk on this. We have 20 minutes, so it's going to be a little bit of rapid fire. But in general, we're going to talk about a bit of background on palliative care and its place in emergency medicine, the resident perspectives on palliative care skills in general, barriers to teaching, interventions, and then some examples of some interventions that have worked at our institution. So a little bit of a history lesson just to kind of get us all on the same page. In 2006, the American Board of Medical Specialties recognized hospice and palliative care medicine as a subspecialty of emergency medicine. And the year later, actually, the Education in Palliative Care and End-of-Life Care for Emergency Medicine course got initiated, which has been very popular since then. In 2011, the model for the clinical practice of emergency medicine, which is essentially what residencies base their education on, added palliative care skills onto their list of recommendations. Interestingly, they didn't actually specify any particular curriculum recommendations and did not add palliative care specifically as a milestone, but at least it's kind of made it onto that list. And then in 2013, ACEP's Choosing Wisely campaign defined palliative care skills as an area for improvement in emergency care. So they essentially said, don't delay engaging available palliative and hospice care services in the ED for patients likely to benefit. So more and more we're seeing palliative care play a role in the ED, which is certainly from our perspective a step in the right direction. So the importance of palliative care skills in the ED, obviously something that we're passionate about and feel like is important. And I think the data really supports that. So as one example of a statistic, 75% of patients with serious pre-existing life-limiting illnesses will visit the ED in the last 6 months of life. And with the influx of baby boomers, again, this is something that we're seeing more and more in the emergency department and is becoming a bigger and bigger thing that are part of what we do in the ED. And obviously something that can really impact the quality of care that we give to our patients. So it's no longer sort of the thing that we turn to when all else fails. A lot of times that's the perception that's been out there for hospice care or palliative care, that, you know, this is sort of the last ditch effort. When we can't do anything else, then you call in hospice or palliative care. And thankfully that's no longer the perception. The other thing that is sort of shown in the literature in a couple of papers is that this can really be an inflection point or sort of that teachable moment for patients. So a lot of patients actually don't have the opportunity to talk to their doctors about palliative care issues such as goals of care and sort of how they want their potentially last weeks to months taken care of. So this is a moment where we can actually, as emergency physicians, talk to patients and say, look, you know, this is a moment of self-determination for you, a chance for you to consider your options and sort of really actually have some sort of input in how we take care of you. And the other thing that's been shown is that the trajectory that we set in the emergency department is actually something that is continued into the inpatient setting. So the intensity of and level of care that we start in the ED often is carried over. So again, this is a skill set that is not only important, but really is our skill set and our skill set to know in the emergency department to do what's right for our patients. So there's an obvious conflict, right? We're talking about resident perceptions and resident education in palliative care skills. And the obvious thing is emergency medicine is all about the resuscitation and life-sustaining care of critically ill and injured patients. So we all come into this with this passion and excitement for sort of the life-threatening moments where we can jump in and fix everything and hopefully save a life literally and figuratively and make it better. And palliative care is kind of the opposite end of the spectrum, where it's more about relieving suffering, optimizing quality of life, and not really this high intensity curative intent that we embrace in emergency medicine in general. So it makes sense that residents would come into this saying, is this really my wheelhouse? Is this really what I need to train in? What I want to do is, you know, fancy life-saving maneuvers rather than palliative care. And so, you know, what are the perceptions that residents have? So we'll look at the data. There's been a number of studies, and this one in particular looked at New York City area residents, and about 24% of residents had a clear idea of exactly what palliative care actually means in the emergency department. and 54% felt that they would like further training in this. And when you look at programs that have EPIC trained faculty, residents in those programs actually felt much more supported in their palliative care training too. And you'll see these numbers kind of, we're not doing an extensive literature discussion, but you'll see that these numbers are kind of true in multiple other studies. So this was a needs assessment that was done of both residents and faculty, and 88% of them felt that palliative care skills were indeed an important competency. 79% felt like they needed more or wanted more palliative care training. And in this study, they actually identified one of the modalities as bedside teaching as the preferred modality. So pretty much, again, it shows that there's teaching that is lacking, and we got to kind of figure out where do we want to intervene and what are the interventions that we can plan for. Similarly, when you look at program leadership, so this was a survey of program directors, associate program directors, and assistant program directors, 64% felt that palliative care was important. Only 59% actually taught palliative care skills in a specific way in their residency. And what they identified as important skills, and then also the top skills that they felt like their residents were capable of, these were things to include crucial conversations, so death disclosure, breaking bad news, difficult communications, pain management, and management of the imminently dying. And the effective educational methods that they identified were bedside teaching, mentoring by palliative care trained faculty, and case-based simulation. So we've identified the fact that residents clearly still have lacking knowledge, and that overall they do have an interest in learning more. And so what are some of the barriers that are in place that are preventing us from making this happen? So the lack of expertise, most certainly, there's still a dearth really of palliative care trained faculty at many, many residencies. That being said, over time, we've seen an increase in palliative care consultation available in most hospitals now. Over 70% actually have palliative care consults available. And the other barrier is the sort of perceived lack of interest, at least from residents and faculty alike. So residents feel like they still are unclear on exactly what palliative care may include, including, again, to the point where many initially sort of think that hospice is really just the last-ditch effort, rather than having possibly, actually we were just having this conversation right before this lecture, that what exactly does it even include? It includes things such as symptom control for chronic disease trajectories. So stuff like dyspnea, pain control, and it doesn't just have to be end of life care. And then the faculty similarly feel uncomfortable knowing exactly what it defines and what are sort of the specific skills that need to be taught. So the while the perception of sort of this is just the last moments of life is something that's been fading, I think there's still a lot of misconceptions out there as to what it can include. So the bottom line is that residents definitely still report lack of training in palliative care skills. They recognize the need for training, but they are unclear sort of on what exactly that role can be in the ED. And certainly with COVID, that's one of the things that's been coming up more and more. Goals of care conversations in resource limited situations, certainly in New York City at the beginning with the huge spike, that was a huge deal, where in some ways there's a little bit of a momentum now to teach these palliative care skills. And like we said, looking at the literature, there's sort of a number of different things that have been identified as key components as to what should be taught. And there's definitely a reoccurring theme, right? As to what these skills are. And for us, sort of the takeaway in terms of what to teach are the breaking bad news and difficult conversations component, symptom management, especially pain, but not limited to pain, and then care of the imminently dying patient. And so obviously palliative care is not everywhere as we would like it to be, at least the two of us. And we know that there are barriers. So what are exactly the ways that we can intervene upon this and address the barriers, and what interventions might actually work?
So of course, Katya and I being associate program directors and educators, our way to approach these things is to teach our residents and hopefully change the culture of emergency medicine as we bring in our new generation of young doctors. So how do we address it? From the literature, we already looked at teaching methods. So we talked about case-based simulation to teach communication skills, bedside teaching for symptom management, and mentoring from our hospice and palliative care faculty. And we want to teach with these residents the skills to try to overcome the barriers that we are not seeing palliative care as a common curriculum in emergency medicine. So we decided to develop We did this. We developed our interventions. We took the literature, we took the recommendations, we took what we were told probably should be taught first, and we decided to go with a low fidelity, high yield philosophy. And we're trying to also figure out, can we teach things that are actually developed to be taught by EM faculty? So we're not relying on our palliative care faculty, our consultants, and we already rely on the emergency department, but can we actually show our residents this is an EM skill that is taught by our faculty? We'd also want to incorporate the resident experience and skill level. And this was essentially taking what they already understood or their experience in the emergency department. And then as the years went on, adapting our cases to adapt to their skill level. And of course, the one challenge was incorporating it into our didactic conference and our clinical shifts. So how would we create these interventions that would easily come into our conference, could adapt and be flexible as the years went on, and were not cumbersome or overwhelming to faculty and of course to us. So the bedside teaching was symptom control and also modeling difficult conversations. And I think this was something that we've actually worked on, having faculty model conversations, or even I've just practiced conversations with residents before they go in, and inclusion of residents. So there was kind of a culture where I originally trained, and even later on, that it was like, well, the attending will go tell the family what's going on, or they're going to go and have the goals of care conversation, and actually giving the resident the confidence and the skills to own their patients. And when I've had the conversation, who's going to tell the patient that their metastatic melanoma is in their brain, or is not getting smaller, or is actually causing more problems, and the resident will say, well, their doctor. And I'm like, well, who's their doctor? Oh, I guess that's me, right? So ownership and empowering them to feel like they actually are okay to take that role with the patients. Something we also do is symptom control. We are very blessed. We have ED-based pharmacists who are often available and can help us with this. We have our palliative care colleagues, but we also want to work with our residents in real time on how to alleviate these symptoms of patients so that it's not frustrating to them when they feel that they are not able to help their patients out when they're suffering. So our next one, and I think our most successful, quite frankly, intervention was our case-based simulation. We started out with just small group-based simulations, and we tried to incorporate over in conference over 2 to 3 years. We do just like 1 hour. We don't do very overwhelming. We just do small increments of it. And this has been something where the residents have actually asked us for more. And good examples of this are just talking about breaking bad news, or even having a discussion that the CAT scan shows that the disease process has progressed, or that their patients are becoming more symptomatic when they're in stage COPD. Our small groups use facilitators and learners, and we tried to include like a range of our PGY years, so PGY 1 through 4, hoping that even our younger residents could learn from the more senior residents. We tried to teach a wide range of PC skills, mainly communication-based, as our residents have really found it. They've said, I'm having difficulty using my words. Like, what words do I use? And it also gives them an opportunity to practice these conversation skills in difficult cases over and over again in a safe environment till they begin to feel comfortable with how to communicate bad news or symptom management or goals of care. And we've been able to include our palliative care faculty, and in the past, when we first started this, but we've also lately been doing it just with our EM faculty. And again, this also begins to show our residents that this is an EM skill, and the faculty are actually able to do this very well and facilitate their groups. So this is mentoring with our palliative care faculty. So this does have involvement of our palliative care faculty. It's been nice when it occurs on shifts. When the PC, we call them PC, palliative care consultants, come into the ED for patient care. This is, of course, usually a 9 to 5 Monday through Friday, though, and obviously I'm not on weekends or overnights. And they are also able to help us when we're doing our curriculum and our interventions to teach medical management in the ED for our didactics and our case-based simulation. It's comfort with managing end-of-life distress, air hunger, and agitation, and comfort with symptom control and advanced diseases. And examples of this are dyspnea, and the interventions that we do try to teach are based on the palliative care literature. And it also helps the residents to feel comfortable with this medical management when they've had the palliative care faculty walk them through the cases. So the advantages of the interventions that we tried are that they don't always require expert faculty. And the cases can actually reflect real-time resident experiences. And we've had the residents actually bring their experiences to us, and we've actually used those later in our cases. And I find the most easy for me as the APD is easily incorporated into conference. It can be used in clinical shifts. And we're seeing like a shift in the culture of our department as more and more residents begin to see that this is part of their skill set and actually use it. I've also noticed that our faculty have been more supportive and actually a lot more supportive of having our residents use it. And I've been reaching out to our palliative care colleagues more often. We also note, though, that there's no standardized pharmaceutical interventions defined for emergency medicine physicians as far as when you're doing management of care. So this is something that we're looking into right now, is defining primary palliative care for emergency medicine physicians and working on how to teach it safely to our residents. So we did get some resident perspectives. Do you guys actually like what we're doing? You know, you do want a little bit of buy-in when the residents feel like they are enjoying what you're teaching them. They show up and they are very enthusiastic. And then they also teach their juniors, which has been very advantageous. So we did do some surveys of our own. Since everyone else was doing surveys, we figured we'll do a survey too. And it actually was interesting is that the pre and post intervention surveys definitely showed an increase of palliative care should be standard EM practice. Now, it was a good survey. In the beginning, they did think so, but we were going up to 99% after the interventions, and almost all of them said they wanted more skills training. And they also said they believe that PC skills training was vital to the residency program. So then 2020 kind of brought a new challenge. Initially, when we were looking at what residents want to be taught and what our residents said they wanted to be taught, it wasn't goals of care. And the impact of COVID on palliative care in the emergency department, I think we can all agree that it was all of a sudden goals of care conversations became vital to patient management. And they were dependent on the palliative care presence in the emergency department. But of course, you know, none of our patients who need those conversations showed up 9 to 5, you know, Monday through Friday. They often came in the evenings or on the weekends, or all of a sudden they've been there for a few hours and then their trajectory began to change. So, goals of care. Residents began to recognize that goals of care skills are vital for emergency medicine. Initially, as I stated before, it was not a top priority. And there's actually been an uptick in our literature for goals of care skills for EPs. And so Annals reference, there was just an Annals article recently, the 5 steps on goals of care conversations in the emergency department. So it's not just us, it's actually all of our colleagues also who recognize that this is going to be, should be a vital part of our training and part of our skill set for emergency medicine physicians. So kind of in conclusion, when we said it's not everywhere, we're definitely concluding that we are not teaching palliative care skills consistently in our residency programs. And it is recognized as a way to decrease barriers for palliative care. So there is a lot of barriers for palliative care, and it's been told over and over again, the literature has said teaching these skills to resident physicians in emergency medicine will actually overcome those barriers. And what we're trying to do is develop interventions and hopefully share with you guys today that they're easy, applicable interventions for resident didactics that you can use to help your residents feel comfortable with these conversations. There's a lot of great resources for these. If you're not sure how to teach them, how to have these conversations, iPal has them, Vital Talks has them, just really simple mnemonics even. It's not as challenging or overwhelming as it may seem. So we are right on time, hopefully. We're actually shocked. And if anyone has any questions, or if Monica, our lovely moderator, wants to let us know if there's anything that anyone wants to know about what we've done to try to decrease the barriers and hopefully increase palliative care being everywhere.
Everyone's probably in the middle of dinner, so.
There's no questions on the chat box either.
All right, well, hopefully it's a little bit of an inspiration at least.
Yeah, hold on, I think I might have a question.
Here, I can speak faster than I can type.
Yeah.
Hi, I was wondering if you guys have anybody on faculty who are you guys PalCare trained, or do you have anybody on staff who's ED PalCare?
So I think, no, we don't. I don't know if Katya, I think you may.
No, we have, I mean, the closest we have, no one fellowship trained. We have one person who has done the EPIC course. I think only one person.
Yeah, I did the EPIC course at SAM one year, but I did the consolidated course, I did the 2-day course, not the big 3 or 4-day course. I think that actually is why we're trying to show how powerful it is that you can actually have people who just have a passion for palliative care actually teach this. You don't have to have fellowship trained people, which was one of the identified barriers, is that program directors and APD said, well, we don't have any palliative care people, so we're not teaching it. And I was like, well, you don't have to have palliative care people. It's just go use the resources, and it's actually really simple. And the case-based learning, or have your palliative care faculty come walk people through like the conversations, and then you use that later in the future for your next sessions with your EM faculty.
Yeah, that's actually what we did too. We had a series of 6 lectures throughout the year, and the first 2 were hosted or jointly taught by palliative care faculty. And I think that really helped to just set the momentum and sort of the enthusiasm. And I think after that, it kind of went, mainly through EM faculty.
So I'm EM faculty, and I'm actually in the middle of a mid-career part-time palliative care fellowship.
That's awesome. That's possibly both of our dreams.
Yeah. Well, so we're trying to create this track so that people who are just, go sort of from being pal care champions to like actually getting, board certified. Like that's the dream. And yeah, so anyway, I think it's great. I think it's great that you're thinking about it. I would, I guess, caution against saying like that it's not so hard.
No.
It's really just that I think it's more that the very basics are not so hard.
Right.
And I think that, we did try to say is that we do have involvement with our palliative care faculty.
Yeah.
So like when we were doing like symptom control, they're very aware of what medications we're recommending, and like they're very good. They were great about helping us the mnemonics, the goals of care conversation. So they kind of gave us the tools, and then we taught it all. So, but we had that mentoring from them. We just didn't rely on them, and then we're able to carry it forward without needing them all the time.
Yeah.
But you're 100% right. And in some ways, I think it's more sort of, it's not that hard to get the enthusiasm going, as opposed to you're absolutely right. Sort of the finer details is, a level that I don't even feel comfortable with. And I'm someone who feels relatively passionate about it,
Yeah, they're very different cultures, the pal care culture and the ED culture. And right. There definitely are some pal care people who are not completely freaked out by the ED, but the vast majority are completely freaked out by the ED.
There's actually a paper, I'm blanking on the title now, but something about like something about wait times, or like the way to like not ingratiate yourself, but like the way to build a good relationship with your ED colleagues is to show up really quickly any time of day, basically.
Yeah. I think
so it was kind of funny because it shows a little bit, like you said, that cultural difference. So
yeah, there's like a series of articles that's like 10 things you need to know. I think it's actually written for pal care. It's written for pal care people, but there's one on like, the top 10 things you need to know about doing a consult in the ED. And like, this is what's important to ED people.
Right. And
there's one like about ALS, it's like, if you're consulting about an ALS patient, here are the top 10 things you need to know about ALS.
Yeah.
And
it's funny. It said something about like drop everything and go if you can. Don't walk out of a family conversation, but go quickly because things are time sensitive. Yeah, so it's true. I mean, I think for them too, there's a lot of barriers to being able to do that easily and efficiently, I'm sure. But certainly
our palliative care teams believe that we should be able to deliver some level of primary palliative care without them. They really do think that we should be able to be there for them and be there for the patient and do basic symptom control and goal of care conversations. And then they'll take over once the patient gets upstairs. And they are actually been very active empowering us and say, we're here for you, but this should be your skill set, just like giving, amiodarone. Like, why can't you do this?
I think is totally reasonable, right? I mean, we say the first 15 minutes of every specialty. So I think doing the first 15 minutes of palliative care absolutely should be within our skill set. Agreed.
I think so, but I also think that there is a burgeoning movement among the very few people who are both EM and PAL care trained to try to encourage embedded PAL care in the ED, which will serve the purpose of having great educational content for residents, but will also, I think, just allow for better PAL care, in the ED.
Yeah, absolutely.
And
We
yeah,
actually don't-
they want everybody to do primary pal care.
Right.
They want nephrologists to do primary pal care. They want like interventional cardiologists to do primary pal care. And it's like, I can understand that. Yeah, just like cardiologists want everybody to be able to read an EKG.
Right.
You know,
Right.
they want to just do the fancy stuff, the complicated stuff.
Right.
Yeah.
But I think it's great that you guys have been working so hard on this and like doing taking such a comprehensive approach to it and a really intelligent, sort of pre and post survey approach to it. That's great.
So I apologize, everybody. I have to jump off because my next talk starts in 5 minutes, and it's actually about primary palliative care in the emergency department, going beyond our consults. So,
Oh, good. I'll go to that one too.
so great. Thanks.
Yeah, thank you for your input. So,
Yeah.
I better go so my poor co-speaker doesn't freak out. Thank you, everybody.
thank you guys.
Good
Appreciate
work.
it.
Anyone else have any other questions at all?
Awesome. Thank you.